week of class, and last week we spent a lot of time understanding the pathophysiology of diabetes, the outcomes of impaired glucose regulation, the high risk for other comorbidities from diabetes, and that leads us into talking about the kidney. So there's a direct link between kidney disease, renal disease, and diabetes, and that's the reason why I want to move in from last week, diabetes, into the next very prevalent condition, which is a condition that not everyone is really familiar with, not only what happens to the kidney, what causes kidney damage, what puts someone in what we know as chronic kidney disease. The other very common term is end-stage renal disease, and where exercise comes into play. So hence, we want to begin taking a look at how do we define renal disease. So kidney failure or end-stage renal disease is a progressive and irreversible deterioration in renal function. So when you think about what is renal function, it's the body's ability to maintain metabolic, fluid, and electrolyte balance, and all of that begins to get out of whack, and the outcome results in retention of urea and other nitrogenous waste in the blood. So when you think about renal disease, I want you to think about the term chronic kidney disease, end-stage renal disease. What is the prevalence? So estimated 37 million Americans have some degree of renal insufficiency. That's about 1 in 7 adults, which is 15% of adults are estimated to have chronic kidney disease. Most don't know they have it. In fact, 1 in 2 people have very low kidney function. They're not on dialysis. They don't even know they have chronic kidney disease. So again, 1 in 3 adults with diabetes, right? What we just talked about last week, and 1 in 5 adults with high blood pressure may have chronic kidney disease. So really prevalent, 150 to 200 cases per million people, new cases each year. Chronic renal failure or end-stage renal disease affect more than 2 out of 1,000 people in the United States. Mortality is right around 20%. Again, 1 in 3 American adults are at risk for this. Demographics that could potentially put people in a higher risk group would be risk factors such as diabetes, we keep saying, high blood pressure, family history of kidney failure, age older than 60, obesity, heart disease, past damage to the kidneys, minority populations, such as African Americans, Hispanics, Pacific Islanders, Native Americans. Especially African Americans is roughly 3 times higher than Caucasians compared to non-Hispanics. So I just really want to hone in on the diabetes and hypertension because that's something in this field of exercise we spend a lot of time talking about. So I want to go over basics of what the kidneys do. So when we understand what the kidneys' jobs are, then it's going to make more sense as to why we're so worried about this. So when you think about the kidney, it's gradual loss of kidney function, right? That's what leads to the disease. Symptoms can include urinating, dizziness, and swelling. Number 1 cause is diabetes. Quick follow-up with hypertension, high blood pressure. And then inflammation, glomerulonephritis. Treatment focuses on the cause, and we're going to go a lot into the treatment. So when you think about kidney function, its job is to detoxify blood, increase calcium absorption, stimulate red blood cell production, and regulate blood pressure and electrolyte. If you take a look at the difference between kidney disease versus chronic renal failure, so function of less than 60%, these people have no symptoms. So how crazy is it that you can lose a huge portion of kidney function and be asymptomatic? On the other photo, we've got chronic renal failure. At this point, it's functioning at less than 10% of what it should be. And so by the time symptoms present, significant loss of kidney function is what the outcome is. And this might look all overwhelming, but the pathophysiology truly is very complex. So regardless of what the method of the injury was, whether it was diabetes, hypertension, different glomerular disorders, once renal damage has occurred, a big long cascade of events ensues. So in response to renal injury, There is thought to be an increase in intraglomerular pressure with hypertrophy. The kidney attempts to adapt to the nephron loss and inability to maintain constant glomerular filtration. So then we end up seeing an increase in permeability of the macromolecules, growth factors, beta, fatty acids, all of these pro-inflammatory markers of oxidized stress, and protein may result in toxicity. So all of this causes all of these different types of cell expansion, inflammation, fibrosis, scarring to the actual glomerular cells themselves. Renal injury results in an increase in angiotensin II production, causing an upregulation of TGF-beta cells contributing to collagen synthesis and renal scarring within the glomerulus itself. So both the structural alterations accompanied by all of these different biochemical and cellular molecular changes seem to account for the progressive renal scarring and loss of kidney function. All of these forms of chronic kidney disease are also associated with tubular interstitial disease. So really very complex with filtration, reabsorption, and secretion within the kidneys itself. So in a very nice, easy to look at visual, we've got a really sick kidney, right? And that really sick kidney is going to end up having some symptoms. So hyperkalemia, potassium, volume overload, vascular access. We are going to be able to see hyperkalemia on the EKG. So if you've had me prior in other classes talk about EKGs, this is one that we usually go over. Paracentesis sensation causes a very odd sensation of tickling, tingling, burning, pricking, numbness in a person's skin, weakness, muscle cramps, but definitely it's going to present deep tendon reflexes, so very delayed deep tendon reflexes, dysrhythmias, the EKG, what does that look like? So in the EKG with hyperkalemia, very big T waves, so the T waves are very peaked. The QRS is much widened and prolonged. Remember, a nice looking QRS is skinny. So the QRS is the width between, it should not be this wide and fat, it should be nice and skinny. This T wave is very tall, very diminished looking T wave, and the QT, which you can't see, is very prolonged and delayed. So this is what we see as what we call hyperkalemia, too much potassium, evident on an EKG, right? So it's got a very odd look. So when you think about hypokalemia, it may cause cardiac arrest, right? So hopefully these little comics, right? Too much potassium in there, changes the EKG can be very damaging. Structural renal damage and diminished renal function is what we know as chronic kidney disease. Again, end-stage renal disease. I'm going to be using, right, interchangeably. So requires renal replacement therapy, and this can be done two ways, dialysis or a transplant. I'm going to get to the exercise portion here, but we really want to understand what is it when we talk about dialysis, or what is it when we talk about renal disease. So chronic kidney disease, end-stage renal disease, affects all ages, ethnicity, and race. 42% are going to be over the age of 60. Historically, dialysis treatment was very limited. In 1972, Congress passed legislation. I should say prior to 1972, access to dialysis treatment was very limited. Selection of patient for treatments was really made by committees, so like committees of medical professions, clergy, lay people, and these committees actually just voted and decided who would receive this life-saving therapy of dialysis. Like, how archaic was that, right? So are you worthy? Anyways, that all changed. Renal replacement therapy is very expensive. Low levels of physical functioning indicate the need for rehab and medical therapy, which is what I want to get into. So we can either do dialysis or kidney transplants. And, those are really kind of the two options. So when you think about kidney damage, diabetes mellitus, we've talked about diabetes, and it's gigantic link to kidney disease, hypertension. Symptoms, the problem with all of this is that when the kidney gets damaged, we really don't see symptoms surfacing until 10 to 15% of renal function remains. So as renal function declines, the end products of protein metabolism begin accumulating in the blood, uremia develops, and adversely affects every system in the body. So the greater the buildup of waste products, obviously the more severe the symptoms. So end-stage renal disease occurs again about less than 10% nephron function remaining. All normal regulatory, excretory, hormonal functions of the kidneys are severely impaired. So we get diabetic nephropathy, hypertension, glomerulonephritis, reflux nephropathy in children, polycystic kidney disease, kidney infections, just a whole host of damage, because remember, guys, what the kidney's job is, right? To filter waste, and now those waste products are accumulating. So progressively kidney failure, we lose excretory functions, regulatory functions, and uremic syndrome sets in. So when you think about what is uremia, fatigue, nausea, malaise, anorexia, neurological symptoms. So there's just overall head-to-toe feeling of not good. Buildup of fluid, so peripheral edema, backflow of that fluid into the lungs, pulmonary edema, and congestive heart failure. So the rate of decline in renal function and progression of chronic renal failure is all related to underlying disorder of urinary excretion of protein and the presence of hypertension. The disease tends to progress very rapidly in patients who excrete significant amounts of protein or have elevated blood pressure than in those without those conditions. So elevated serum creatinine, blood urea nitrogen, reduced glomerular filtration rate, loss of regulatory function, so inability to regulate extracellular volume, electrolyte concentrations, loss of excretory functions, buildup of toxins in the blood. So volume overload, hypertension, congestive heart failure, impaired generation of ammonia, hydrogen ion, really metabolic acidosis. I'm giving you all of the science behind this, right? So really just a giant backflow. Uremia is the big one, insulin resistance, high glucose levels, high cholesterol and lipid levels. Again, what do they feel like? So incredible deterioration, overall decline in physical well-being, signs of, all of these are signs of anemia, fluid backup in the tissues, loss of bone mineral, hypertension, significant fatigue, shortness of breath, loss of appetite, restlessness, change in urination patterns, just overall malaise, just not feeling good. And this really odd feeling of itchiness, right? That's the, if you're not familiar with the word, it's the third from the bottom, pruritus, which is this strange sensation in the skin. So who are the people that are going to take care of them? This is us in this class, right? Multidisciplinary team, medical history focusing on renal-related issues, comorbidities. When you think about the exercise physiologists, right? So obviously social workers for the quality of life problems, dietitian play a lead role, exercise physiologist, close attention to any cardiac history, type, frequency of dialysis treatment. So must pay close attention in the patient's chart and medical history of what strategy of exercise should be considered for the treatment, and what burden is the patient experiencing, physical burden are they experiencing. So medical considerations, diagnosis is based on the level of serum creatinine and blood urea nitrogen. Treatment of renal failure depends again on how well the body is, what level of clearance they have. Initial management could begin with dietary adjustment with protein, sodium, and fluid intake. That's a really very, very specific diet we need, the patient needs to follow with end-stage renal disease. Renal replacement usually follows diet. So 3 alternatives to renal replacement: hemodialysis, peritoneal dialysis, and transplants. Those are, again, the 3 methods of treatment. So you have a very strict diet followed up with 3 alternatives of what do we do to help with replacement. So although transplant is a preferred method, patients need to be free of all other life-threatening illnesses to be considered for transplants. So hemodialysis is the most common therapy for renal failure, although it requires significant time throughout the week at renal centers. The 3rd alternative for renal therapy replacement is peritoneal dialysis. This is a method that we seem to be least common in the United States, but more frequent in other countries. I'm going to talk about this so it makes more sense to all of you in a moment. So medical management of what we're looking at for chronic renal failure until we end up seeing creatinine clearance really getting down low. Dietary measures, very, very low protein diet is what they want to follow. So you want to consume not a lot of protein because they're not filtrating, right? The kidneys are not working. Dietary sodium fluid restrictions. So management really is an important thing to look at what they're taking in. Low protein to decrease the symptoms of uremia and delay the progression of the disease. Fluid restrictions because the fluid regulation mechanism of the kidney itself are deteriorating in function. Any excess fluid taken remains in the system. So if you're taking in too much fluid, it's going to remain in the system. Progressively deteriorating in the renal function will ultimately result in peripheral edema, so more fluid overload and the extracellular fluid and pulmonary congestion as well. So diet is really interesting piece of the puzzle. I'm going to have you read for this week's assignment an article, and usually I'm not that focused in the exercise physiology class at understanding blood values, but with our kidney patients, this is really what we want to be looking at. So this lists lab values for healthy patients versus those patients undergoing dialysis, so our classic kidney disease patients. So abnormal lab values, the creatinine is one we really want to look at. So lab values of creatinine. I want you to also take a look at blood urea nitrogen. I also want you to take a look at the creatinine clearance. So when you take a look at the creatinine levels, right? Normal range versus typical range of patients. When you look at, the creatinine clearance levels. So really important to take a look at the differences in some of these values. We're going to look at that in the article. So what is dialysis? Dialysis is what we see most common in the United States. So half of the patients with end-stage renal failure eventually require dialysis. It's diffusing harmful waste out of the body. It's helping to control blood pressure. It's helping to keep safe levels of chemicals in the body. We have two types of dialysis. We have hemodialysis, which is again more common in the United States. The fellow lying in the hospital or in a clinic, right? And peritoneal dialysis, which can be done at home. So when you take a look at hemodialysis, these are people that are going to a clinic 3 to 4 times per week. It can take up to 2 to 4 hours to sit still and have this process done. So the machine itself is filtering blood and it's returning it back into the body. So as you see, it's the machine is doing the filtration. So it's pulling out and being able to clean and bring it right back into the body, right? This is the process of hemodialysis. The complications with hemodialysis are hypotension, right? Decreased plasma volume happen, vasodilation, autonomic dysfunction, cramping from we see a lot, anaphylactic response from just the dialysis membrane that usually happens in the it can happen in the very beginning of treatment. So cardiopulmonary arrest, itching, I keep talking about the itching, the restless leg syndrome. However, it's life-saving, right? It's a great way to get that waste out of the system. However, it definitely has some side effects. So how do they get access? They usually can do a temporary site or they can do an AV fistula where the surgeon instructs an artery and a vein, or they can do an AV graft, which is man-made. So they have a port that's going to be put in, right? This temporary catheter, so they can get access to do the hemodialysis or the AV fistula or graft in the arm, right? So it can either be temporary catheter up here, or oftentimes it's going to just be the graft that's in the arms. That's one way. The second way is peritoneal dialysis. Most other countries, peritoneal dialysis is preferred over going to dialysis treatment centers. Okay, so I'm going to talk about peritoneal dialysis. It's not used as frequently in the United States. Dialysis fluid centers, the fluid is going to enter the body through the peritoneal cavity, right, so the abdomen really, through a permanent catheter placed over the lower abdominal wall. It happens over an 8 to 12 hour period while the person is sleeping in their own home. Why would a patient choose peritoneal dialysis? They have more freedom, less dependency on a clinic. They can live their life during the day and then come home and while they're sleeping do the peritoneal. So complications associated with peritoneal dialysis, infections, possibly at the site of where the catheter is, hypotension, again, similar with the change in fluid overload, hernia and leaks. So, similar, except this hemodialysis versus peritoneal dialysis, one is at home, one is in the clinic, and the site of where the access is happening. So we have, what are the three things, right? We've got dialysis in the clinic, usually the arm and the fistula of the arm, hours and hours sitting there, right? 2 to 4 hours. The second way that I just spoke about is peritoneal dialysis done in someone's home using a port through the abdomen while they're sleeping. And then the third is a transplant. Preferred treatment really is a transplant, usually younger, healthier patients that are going to be a candidate for transplant. Transplants are wonderful. If you have donors to give a kidney, right? We need donors. We need kidneys to put in for the transplant. They're going to take some immunosuppression medicine to avoid rejection. So long-term complications associated with the transplant could be rejection. Cardiovascular disease could set in, and infection could set in, but usually the transplant does a great job at really helping this person just live a better quality of life. So some considerations I want us to think about. What does all of this mean to an exercise professional? That we want to understand, if they have an arm fistula, do not take blood pressure on that arm. Protect the arm from injury. Control any obvious hemorrhaging. Bleeding will usually be arterial. Maintaining direct pressure, so no IV on the same arm of that fistula as well. When you're looking at dialysis-related problems, they can be lightheaded, so you want to give some fluids, hypotension, irregular heart rates, equilibrium syndrome, so a little bit of confusion. Again, they're having a lot of fluid change in their body during the dialysis. This slide I have it up here to kind of let you know, over years, when you look at what we call evidence-based research, exercise capacity in patients with end-stage renal disease is what we're looking at. So the HD stands for hemodialysis, continuous ambulatory, peritoneal dialysis. These are people at home versus the transplant. What I want to explain to you is that most patients on dialysis are very severely limited physically. Exercise capacity is low, primarily due to leg fatigue. Peak oxygen uptake is reported to be low, 60 to 70% of normal. However, it can drop down as low as 39%. Uremia affects nearly every organ in the body and has a very significant marked degree of excess limitation in these patients with uremia. Reduced exercise capacity is influenced by all of these problems: uremia, muscle blood flow, muscle oxidative capacity, myocardial function, low physical activity level. So exercise testing is not usually needed because we're just going to assume they're at low levels of exercise capacity. What I want to tell you, though, is that we want to get these people moving. So this slide is kind of the brunt of the brunt of what I want to tell you. So we know that exercise, right, being sedentary, aging, chronic disease, dialysis, as people get older and as they start feeling more ill, they end up becoming more sedentary. And this just dominoes and snowballs way more problems. So the more they sit still and not do anything, their fitness goes down, muscle mass, sarcopenia happens, physical performance, self-reported functioning goes down, disability, mortality. What we see with chronic kidney disease, end-stage renal disease, is a whole host of problems, right? Diabetes, hypertension, insulin resistance, endothelial dysfunction. We want to stop this process. We want to try to, at least if we can't stop it, slow it down. So we want to get them moving. We don't want them to decondition this much. So exercise is important. Exercise capacity is going to be very low in those in peritoneal dialysis patients, but it can increase. We can see significant increase, especially in those among transplants. Some of the stuff we want to look at is just basic functioning, stair climbing test, a 6-minute walk test, a basic sit to stand, just being able to get a general perception of how functional they are. So what we want to take a look at is Flexibility, range of motion, strength, and obviously cardiovascular aerobic exercise. Lots of barriers, lots of malaise, so lots of muscle aching and weakness. Time requirements of treatment. When are they going to the clinic for dialysis? Or are they doing peritoneal dialysis at home? Do they have any encouragement at home? Are they fearful? Usually they will. Patients are sitting for hours just to get the dialysis, then they go home and they usually sit more because they're tired. The thing that research has shown is that we should be doing exercise within the first hour of treatment. So while they're sitting there, we can have them riding a bike, and I'll show you some photos of that, and exercising on non-dialysis. So really taking a look at healthcare providers, providing low-level lifestyle changes, getting them moving. Ideal time, again, is going to be early in the treatment and then on their non-dialysis days. So we know they're going to be greater risk of hypotensive blood pressure a couple hours after dialysis because of that continuous removal of fluid throughout that time. We have decrease in cardiac output, stroke volume. I mean, pressure, you want to be careful. Seated exercises are great, such as an arm ergometer. This is what I'm showing you here, so they can sit and they can be moving their arms. If they're at home, obviously not on dialysis because they're going to be using their arms. During dialysis treatment, right, you see she's getting dialysis here on their arms, and now we've got the bike, right? Here's another guy on a stationary bike. Here's a fellow doing some seated resistance training. This is what exercise looks like in a dialysis treatment clinic. Very beneficial. Peritoneal dialysis, these people are at home, so they can be exercising in the middle of dialysis exchange before adding new dialysis fluids. You want to keep the catheter clean. You want to be careful of arm or wherever the port is. With peritoneal dialysis, again, that's going to be in their peritoneal, their abdominal cavity, so being careful with abdominal exercises. Transplant patients, benefits are exercise, right? We don't want them to gain weight, so weight management, regaining physical functioning post-transplant, helping to maintain muscle mass. Other benefits similar to hemodialysis patients with improved blood flow and, again, maintaining muscle mass, recovery from surgery. We want to, obviously, transplant patients going to be cleared from their physician before starting exercise. Walking immediately is the best exercise for our post-transplant patients. I want to let you know that, and I have a link here. I'm not going to click the link. I would love for you to click the link to look at the volume of people you may or may not realize who have been diagnosed with chronic kidney disease. These two fellas here both had kidney transplants. It is significantly more prevalent than what people think. It just doesn't get the attention that it deserves. So when you think about your kidneys, I believe March is National Kidney Month. So you might hear a little bit more of it in the news now that I've done this lecture. So what is a prescription going to look like, right? So aerobic exercising, walking, cycling, start with intermittent exercise, always intermittent, strength training, starting low and building up. When you think about those with transplants, similar thing, right? So the difference here is the intensity. Let me go back, right? The intensity was just based on how they felt, low level intensity. When we take a look at the transplant, our intensity, we're usually going to be able to get them up to a good amount of activity level. I love working with transplants, heart transplants, kidney transplants, because we can really titrate up progress up an exercise program and really gradually see some well-tolerated exercise among transplants because those new organs are really doing an incredible job. This is available. If you're training anyone who is got kidney disease, this is a great resource to let you know. It's free material, incredible, valuable source of how to live, how to treat people on dialysis and cardiac rehab. We have a lot of patients that are doing cardiac rehab and dialysis treatment at the same time. The Surgeon General warning, as I should have this in all of my lectures, physical inactivity may be hazardous to your health. I love it as I laugh. Organ donations. I think this is a good plug for me to share with you. Are you an organ donor, right? Think about organ donation. There are different types of organ donations, right? You can have donors that happen upon death, and then we have living organ donors that can be donated. And when you look at living organ donors, you can donate one kidney, a lung, a portion of a liver, pancreas, intestine. Deceased, right? When someone has passed, we've got what are the options, right? So 2 kidneys, a liver, 2 sets of lungs, obviously, the heart, the pancreas, the intestines. Recently, not that long ago, they added face and hands to the list of organ transplants, corneas, tissues, heart valves, stem cells, cord blood, bone marrow, platelets. You can be a blood donor. There are many, many levels of donating. I used to, when we were in the classroom, always have a speaker come in and talk about organ donation, from just donating blood to donating, people who donate their full body, whatever is healthy enough to reuse. Sometimes I feel like once you meet somebody who's, let's say, had a donated heart, or even this lecture, a donated kidney, when you meet someone who can touch you, share a story as to who that donor was and what that donor's organ has done to their life, it can be really impactful. So let's go back to exercise. Let me leave on the thought that you play an important role as an exercise professional. Here's an importance of research that was just published in 2018 on the importance of strength training in chronic kidney disease, where it looks at both aerobic and strength training exercise, better than doing just aerobic by itself, and looking at when they're exercising, leg strength, walking distance, quadricep muscles, right? Anytime we can get somebody moving more than just sitting still is going to be beneficial. So this is one. How do we stop kidney disease? The science behind diet, and diet is a big, big role in this, and you're going to read that in the assignment you're going to do for this lecture, this unit, as well as keeping them moving, right? Slowing down the progression of kidney disease, slowing down heart disease. They seem to go hand in hand. Heart disease and kidney disease, very similar comorbidities and risk factors: sedentary, obesity, high blood pressure, diabetes. So improving the filtration rate is important, that they keep moving. And that's really, what I want to get at is a strong kidney is regular light exercise, eating a well-balanced diet, drinking good water, less sodium, not smoking, and really no alcohol, because that's the other level of kidney disease.